Welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we will talk about general aspects of pacemakers and other implantable cardiac devices. For that, we count with the collaboration of Dr. Tomás Benito González, part of the Interventional Cardiology Unit of the Hospital de León. Join us! Implantable cardiac devices are a set of electronic artifacts that are implanted below subcutaneous cell tissue with the intention of controlling cardiac rhythm using endovascular electrodes. Generally speaking, these devices are shaped by two main parts, the pulse generator and the electrodes. The generator is a small processor composed of an electronic circuit that obtains its energy using a lithium-ion battery that can last between 5 to 10 years approximately. A connector block allows the electrical stimuli generated to be transmitted to the electrodes. In this way, endocardium of the cardiac cavities is directly stimulated. The implantable cardiac devices can be grouped according to some of its characteristics. For example, durability. These devices can be temporal or permanent. Temporal devices are practical, being frequently used in emergency situations and for a very few time, minutes, hours, days, while the clinical situation of the patient corrects or a permanent device is implanted. These temporal devices can be transcutaneous, when the cardiac stimulation is achieved using electrodes attached to the skin, such as external pacemakers and external defibrillators. Transthoracic, when the cardiac stimulation is achieved using electrodes that cross through the thorax wall directly to the epicardial surface, such as pacemakers implanted during cardiac surgery. And transvenous, when the electrodes reach the heart following veins. The most frequent accesses are jugular, subclavian, or femoral veins. Examples of these devices are the transient percutaneous pacemakers. On the other hand, permanent devices tend to be implanted in a little and planned surgical intervention. Though they are named permanent, they do not possess an undefined duration because current batteries are not rechargeable, so the patient needs to be re-intervened to change the device for a newer one when the battery runs out or another complication exists. These devices usually stimulate the endocardium, but sometimes can be necessary to place the electrodes in the epicardium, for example, in pediatric patients or in patients with endocardial infectious processes. Location. Implantable cardiac devices can stimulate one, two, or even three cardiac chambers simultaneously. Single-chamber devices possess one electrode located in one of the cardiac chambers, most frequently being the right ventricle or the right atrium. Dual-chamber devices can stimulate two cardiac cavities using one or two electrodes, the most frequent being the right ventricle and the right atrium. And finally, the triple-chamber devices can stimulate three cavities. These normally are the two right cavities and the left ventricle. The stimulation of right cavities is usually endocardial, using electrodes that come from the superior cava vein, while the stimulation to the left ventricle is usually epicardial, using a resynchronizer electrode that reach the lateral wall using the sinus venosus. Fixation. The devices can have electrodes with passive or active fixation mechanisms. These electrodes will be chosen by the operator during the procedure according to the clinical situation of the patient. Polarity. The electrodes can be classified according to their polarity. The monopolar electrodes are cables with a stimulating negative pole localized in the distal end in contact with the endocardium, while the frame of the device works as a positive pole. This generates an evident spike in the electrocardiogram, but facilitates electromagnetic interferences in the device. This is why electrodes with two poles are preferred nowadays. These poles are located in the distal end of the cable, substantially reducing the distance of the circuit to 3 centimeters approximately, lowering the risk of electromagnetic interferences and also the voltage of the stimulation spike. Function. According to the function it performs, implantable cardiac devices can be classified into three groups: pacemakers, implantable cardioverter defibrillator, also known as ICD, and resynchronizers, also known as cardiac resynchronization therapy or CRT. Let's take a look at each one of them. Let's begin with pacemakers. As you know, pacemakers are devices that detect heart rhythm with the intention of stimulating myocardial contraction when heart frequency decreases or disappears. But how do they achieve it? Very simple, with two electric functions, detection and stimulation. Detection is also known as register and consists of recognizing the intrinsic electric activity of the heart. Using a series of algorithms, the device integrates that information, registers it, and determines if a bradyarrhythmia does or does not exist, treating it with a cardiac stimulation if necessary. As you can see in this scene, algorithms are represented schematically inside the inferior rectangle, so anytime a heartbeat occurs, the electrode detects it using the register function. Immediately after, the period of detection begins. This is a period available for the heart to activate spontaneously, and that is represented in our diagram with a continuous and upward blue line. With every new heartbeat, a new register occurs, and a period of detection begins again, and so on until, in any moment, the heart frequency decreases enough so that the period of detection runs out and activates cardiac stimulation. This electrical stimulus must be intense enough to achieve an effective cardiac contraction. This is called capture, but without triggering a contraction of adjacent non-cardiac muscles, for example, the diaphragm, nor liberating unnecessary energy that leads to early battery depletion. And finally, it is important to point out that pacemakers can recognize tachycardias, but they are not designed to treat them. Another aspect that we must know about pacemakers is the international nomenclature used to design the functions of cardiac stimulation. Although the complete nomenclature includes 5 characters, the most usual is to use the simplified version of 3 characters. In this way, the first letter indicates the stimulated chamber, being the options A in case of atrial stimulation, V in case of ventricular stimulation, and D in case of dual chamber stimulation. The second letter describes where the register is produced, being the options A for atrium, V for ventricle, D for both chambers, or O if there is no register. Finally, the third letter indicates the generator's action mode after detection of the cardiac activity. In this way, the response to the register can be described with a letter I when there is an inhibition, with a letter T for triggered, with a D when both occur, and with an O when nothing occurs. As extra data, when the letter R exists as a fourth letter, it means that the pacemaker contains a sensor that can control the frequency of stimulation according to the physical activity of the patient, which might result really helpful. Let's continue with the most frequent codes of stimulation. These are AAI. It is used less frequently every time. It could be helpful in cases of sinus dysfunction because it only detects and stimulates the atrium. VVI, it is usually used in older patients with high-grade AV block and atrial fibrillation because it only detects and stimulates the ventricle. And DDD, it is usually used in young patients with high-grade AV block or patients with heart failure carriers of an ICD or a CRT because it is capable of registering and stimulating different chambers simultaneously in order to achieve a more physiologic pattern of activity. Now let's take a look at the electrocardiogram. This is the classic electrocardiogram of a patient with AAI stimulation. As you can see, a stimulation spike exists just before the P wave, so the P wave will have a different form compared with the sinus P wave, but QRS complexes will not suffer any changes because ventricular depolarization is achieved using the cardiac conduction system. In this way, we can identify some captured failures when we see spikes not followed by P waves, or register failures when we see spikes independently of the atrial activity. On its own hand, VVI stimulation exhibits a stimulation spike before every QRS complex. independently of atrial activity, because it only detects what happens in the ventricle. The most usual process is that the pacemaker's stimulation is produced in the right ventricle apex, and this is why QRS complexes are usually not narrow, with an image of left bundle branch block and superior axis. This way, we can identify capture failures when there are spikes not followed by QRS complexes, and register failures when the spike appears inside a QRS complex. Finally, DDD stimulation has a lot of presentations. It all depends on the needs of the patient. The classic image characterizes by showing two spikes simultaneously, one with the P wave and another with the QRS complex. In any way, the stimulation is coordinated with the register of both chambers, and that is why we will see the QRS spike coupled with the atrial activity. Let's talk now about chest X-rays. This is a normal image of a single-chamber pacemaker located in the apex of the right ventricle. As you can see in the lateral projection, the electrode locates near the anterior chest wall because the right ventricle is anterior to the left ventricle. On its own, this is the look of a right cavity's dual-chamber pacemaker. The second electrode is located in the right atrium, and so its location is superior or above according to the electrode in the right ventricle. Instead, when the second cable is a CRT cable that goes to the left ventricle, its aspect is totally different. As you can see in this lateral projection, this chamber is posterior to the right ventricle. Finally, we must remember that in some posterior-anterior chest X-rays, the right ventricle electrode can appear on the diaphragm, but this does not mean there is a heart perforation. It is only an image overlap. In this way, we can only suspect heart perforation when the tip of the electrode clearly abandons the heart shape. Very well. Now that we know what they are and how they work, let's swipe through the rest of the devices. The ICDs are devices more complex than a pacemaker because it does not only possess functions of detection and stimulation, but also a defibrillation function. This is possible thanks to the existence of a coil located in the distal end of the electrode. And even though electric discharge was of greater power compared with the one to stimulate the heart, it is truly much less voltage compared with the one used by external defibrillators. Although an ICD can work as a pacemaker, the objective of these devices is to detect fast ventricular arrhythmias and treat them with an overstimulation or with a defibrillation. These therapies restored heart rhythm and reduce the risk of sudden death. Finally, CRT refers to those devices that are used with the intention of synchronizing contraction of both ventricles in patients with left bundle branch blocks. This allows the ventricular system to be more effective, increasing the heartbeat volume, which is beneficial in patients with heart failure and severe ventricular dysfunction. Let's take a look at one of these patients. As you can see, left bundle branch block triggers an asynchronous and not very effective ventricular contraction, which produces a severe ventricular dysfunction and develops a heart failure. However, as you can also see, the patient was treated with a CRT, and this way, mechanical contraction improves, and with it, the ejection fraction. As you can see, the world of heart devices is quite interesting. However, our time is over. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye.